Beltagi and myself, and supported by Khan's members who are attending today, both Professor Nasser Oganda, Graham Fegan, and perhaps later Moody Qureshi. I want to welcome our esteemed speakers today who are going to give us an insight into their experience with managing pediatric brain tumors. Both our speakers are vastly experienced and will be speaking on conditions that they have tremendous experience with. Our first speaker is Professor Wen-Tu Sao. Wen-Tu is a seasoned at international congresses. He's professor of neurosurgery, previously at the National Neuroscience Institute of Singapore, which is a very prestigious neuroscience institute, one of the top in the world. He holds multiple master's degrees, and I'm not sure that many people know this. One of them is an LLM, so he's got a law degree as well. So he clearly will give us that perspective as we go along. He serves in various senior executive roles in various institutions, both national and international, including the ISPN, the IFNE, the AASPN. And I think, interestingly for all, will be meeting president for both the ISPN and IFNE meeting, which I'm sure he'll show towards the end of his talk. That's towards the end of the year in Singapore. So Wen-Tu, it's a great privilege to introduce you. And I think out of respect for both our speakers, I'll introduce them just before their talk. So just before you give yours, I think you warrant an independent introduction. So Wen-Tu, without anything further, I'm going to hand over to you.
Thank you very much, Brennan. So let me just share my screen. Good evening to all of you, and hope you're having a good day. All right, so I've been given the topic of pineal region tumors and talking on nuances of management. And I thought we'll just find out what the word nuances means, and it's really subtle, different shade and so forth, as you can see in the slide here. But basically the idea is that every patient is different. Every pineal tumor that we see is not the same as the previous one. There are actually geographical genetic differences, and as I will mention, pineal tumors are more common in my part of the world, but the majority of them are germ cell tumors. So the management approach, as I discussed here, may be different in your part of the world where germ cell tumors are less common. But nevertheless, I think it's important that we learn the basics of what we need to do. Now, the pineal tumor is also known as the third eye. It's a lobular structure containing of pineocytes, mainly some astrocytes. And these pineocytes are specialist neuroepithelial cells that secrete melatonin, serotonin, and pineal peptides. And I think we know what the function of melatonin is, but basically these are the modulator of circadian rhythms and the body's cyclic variations in response to environmental changes. And with the tumor itself, they are actually very uncommon, and there are multiple histological sites. And as I mentioned, major racial, geographical, epidemiological differences and incidences and frequencies of these types. Now, it accounts for only about up to 1% of all brain tumors in children, but in our part of the world, it can make up to about 8%, all right, of all pediatric tumors. The tumors arise either from the cells of the pineal gland themselves, the pineocytes, or from germ cells or structures in or around pineal regions. So basically, from the pineal sites, you get the pineocytoma. We have the pineal parenchymal tumors of intermediate differentiation and the pineoblastomas. From the germ cells, you get germinomas, non-germinated germ cell tumors, teratomas, and then you see other types of tumors, gliomas, ATRT, lipomas, meningiomas. So looking at the pineal region tumors, so you can see this is another list showing the different types of tumors that you tend to see around the pineal region, and the most common would be for us, germ cell tumors, and then rarely the pineal parenchymal tumors, and in children, mainly pineoblastomas, and then you see other types of tumors around the region as well. Now, as far as germ cell tumors are concerned, these are thought to arise from primitive germ cells which fail to migrate normally. As I mentioned, all right, the largest percentage of all pineal tumors are basically where we see in the East. And if you look at the chart, all right, so looking at pediatric tumors found in East Asia, incidence of pineal germ cell tumors is actually 8 to 15% compared to a smaller number in the other part of the world. And of course, the most common of the germ cell tumors is the germinoma, and they tend to occur within usually the first or second decade of life. Now, as we have heard, there are actually several different types. So the most common would be the germinoma. There are various other names. And then the next group is the non-germinated germ cell tumors. And these include the embryonal cell carcinoma, endodermal sinus tumor or yolk sac tumor, choriocarcinoma. Then the teratomas, which could be either malignant or mature, which are benign, and intermediate immature. Then we have what they call mixed germ cell tumors and the tumor. You can see this is a tumor that's arising from both the pineal as well as the suprasellar, and it's a bifocal tumor, and most of them are germinomas. And one way of looking at how they originate, so a germ cell can become a germinoma, or it can become from the cells of a tumor, a totipotential cell. Then it can become a embryonal carcinoma, which could, if it contains extraembryonal tissue, is either trophoblast, which is becomes a choriocarcinoma, or if it contains yolk sac, it becomes a yolk sac tumor. Or else, if it's a purely embryonal tumor, it will become a teratoma. Right? And the characteristics of germ cell tumors, right? So usually 80% grow within the third ventricle, usually in the pineal region, but also in the suprasellar region. Other sites include the basal ganglia, ventricles, and the spine. Interestingly, pineal germ cell tumors occur predominantly in males, whereas the suprasellar ones, there's a higher incidence in the females, right? And the most important part of germ cell tumors is the presence in the blood and, or sometimes just CSF alone, or both, of tumor markers. And they express the embryonal markers, beta-ACG, alpha-fetoprotein, and then those that do that are called non-germinated germ cell tumors or secretory germ cell tumors. Now, placenta alkaline phosphatase or placenta lactogen, actually only pure germinomas secrete them. And then actually, so the analysis of the serum and CSF presence of these tumor markers will guide further measurement. Practically, we only nowadays just look for beta-ACG and alpha-fetoprotein because these are the types the PLAP and PHL are actually very, very difficult to do. And the thing is that the presence of abnormal levels of tumor marker, right, and the presence of a pineal or suprasellar tumor on MR on imaging actually will indicate a germ cell tumor, right? Although the pattern of tumor marker possibly is not necessarily diagnostic of the specific histological type per se, right? So the embryonal cell carcinoma being the least differentiated actually give rise to both alpha-fetoprotein and beta-ACG. The yolk sac tumor, only alpha-fetoprotein. The choriocarcinoma, only beta-ACG. Now, in teratomas, the mature teratomas, benign, do not secrete any, but the immature, the malignant ones may actually secrete either alpha-fetoprotein and or beta-ACG. So looking at the way you test, right, so basically, if you have looking at beta, if it's slightly positive but very low, it could actually be a germinoma still, if it's beta-ACG is positive, because these are due to the syncytial trophoblastic cells that are present in germinoma. They secrete beta-ACG, but the dose is not very high, right? Whereas if it's very high, it's either a teratoma or usually embryonal carcinoma or choriocarcinoma. If it's alpha-fetoprotein, usually it'll be either embryonal cell carcinoma or endodermal sinus tumor, and most of these levels have to be much higher, okay, than 50 IU per liter. Now, the other thing that you sometimes see is what is called a growing germ cell tumor. Now, this is actually a tumor that is mixed with both a benign tumor and either germinoma or a non-germinous germ cell tumor. So teratoma plus a malignant component. So after adjuvant therapy, chemo and radiation, the tumor may shrink initially, but then continues to grow. And that's because, as we mentioned, the tumor in reality is a mixed germ cell tumor, and the malignant control has been controlled with chemotherapy and radiotherapy, but the benign component, a benign teratoma, continues to grow and increases in size. right? So like, look at this case where this boy presented a pineal tumor, right? The beta HCG was slightly raised, suggesting a germinoma. Now, this patient was started on chemotherapy, and after a few courses, you can see that, you know, the part of the tumor is gone, but it actually continued to increase in size, right? So those are the germ cell tumors that you see. Now, the tumors of pineal parenchymal cells, so would be the pineocytoma, which is benign, usually seen more in adults than in children. Although I have seen one case, you get this pineal parenchymal tumors with intermediate differentiation of the PPTID, not so common. They are probably a grade 2-3 type of tumors. And then the pineoblastoma, which is in the past called a pineal PNET, because they have the small blue round cells as well, and they are very aggressive and very malignant, right? Now, other pineal tumors that you see would be things like glioma, right? So GBMs could be present in this part of region as well. You see here also tactile plate glioma. You can see it clearly in this case, right? Sometimes they can be low grade, and these are low grade gliomas. And then, of course, you can get meningiomas, and also, like in this case, setting down, this is actually a lipoma. Right. So what are the signs and symptoms? Of course, the most common would be signs of raised intracranial pressure, because many of these tumors cause hydrocephalus, but they can also be present from large tumor masses, so you can get headaches, nausea, vomiting, papilledema, and signal palsy. Classically, you will see Paranormal sign. And then, of course, as the tumor goes into the posterior fossa, you could have cerebellar signs. Now, interestingly, you get endocrine disturbances in pineal tumors, and these are mostly germ cell tumors, because they can be supracellular involvement. So you can get diabetes insipidus or precocus puberty as well. What are signs and symptoms? So as I mentioned, raised pressure, headaches, and you can also, and nausea, vomiting, and so forth. Then you get seizures, visual field defects, sometimes motor sensory symptoms, and classically Paranormal syndrome. In infants, you can get lethargy, irritability, again, because of increasing head size, so because of hydrocephalus, sun-setting eyes. Right. Paranormal syndrome actually is caused by pressure distortion on the pathways of midbrain, right? Basically, when there's compression on the colliculus, compression on the tactile plate, the colliculi, and then the underlying pathways. And it's a combination of impaired outward gaze, so the sun-setting eyes, impaired down gaze, pupillary anomaly, loss of combination reflex, and refractory nystagmus. Right. Now, imaging, right? So if you see a double lesion like this, right, you virtually always say that this is a germ cell tumor, most likely germinoma, although some secretory germinomas can, germ cell tumors can also be this bipolar, right? But usually there would be a single lesion. Right. So the aims in management is actually to obtain CSF4 markers, alpha fetoprotein beta Z, and if your country does able to test for PLAP, we don't have this. I think Japan and some parts of the US have. Then actually you can test for germinoma, right? And how you obtain it? Usually you can, of course, you can take it from the blood, but sometimes it's negative, and you may need to take from the CSF, right? Then of course, the next thing is to relieve hydrocephalus. Then you want to get a biopsy for histology, especially if the markers are negative, and then consider craniotomy excision if tumors benign or chemo radiosensitive, and of course staging. And the reason we say this is because actually a lot of the germ cell tumors are actually very chemo and radiosensitive, and then the diagnosis is more important than surgery to excise it. It's not really needed. Right. So basically, when you do surgery, you want to get a histologic confirmation. Right. If you have to say this is a teratoma or a pineoblastoma, you want to consider gross total resection with minimum morbidity. You want to restore CSF pathways, but many times you may not be able to do that without putting in a shunt. And of course, the surgery also need to offer a better outcome than that associated with natural history of non-surgical treatment, or even better outcome than surgical treatment if you're considering chemotherapy. Right. So what are the options for pineal tumors? Obviously, first thing you have to consider a shunting procedure for hydrocephalus. Now, this could be a shunt itself or ETB. Then, of course, then consider biopsy, and then surgery and second look surgery, and then, of course, chemotherapy, radiotherapy, and especially the pineal, the germ cell tumors, you may want to consider cranial spinal axis radiation, right? Because the pineal germ cell tumors are chemo radiosensitive, whereas the pineal blastomas, you treat them as for medulloblastoma because they're very aggressive tumors. So the hydrocephalus itself or pineal tumors, you can consider ETV, you can consider shunt, or you can consider ETV and biopsy, right? So basically, if you do a shunt, of course, there's a risk of tumor dissemination about the shunt into the abdomen, and then these patients are usually stuck with a shunt, and you have lifelong complications. With ETV, endoscopic ventriculostomy, you also consider biopsying the tumor at the same time when you do the ETV, right? A question has always been, do you do ETV and biopsy or biopsy the ETV, right? I think for me, the priority is for treatment hydrocephalus. And so the direction of the scope should be the way that actually you do the ETV safely, but sometimes that may mean that you may not be able to see the tumor, right? And then of course, sometimes when you're doing endoscopy, you can see metastatic deposits on the floor of the third ventricle, and you can even biopsy those as well. Right, so basically the management of hydrocephalus using ETV in pineal is quite straightforward. The standard burr hole just in front of the coronal sutures and about 2-3 cm lateral to the midline, right? And then you go in, at the same time, you can also just look backwards and consider doing a biopsy. Right, so looking at this case where it's a 1-year-old boy person vomiting with unsteady gait, serum markers are negative, you can see there's quite a severe hydrocephalus, and you can see the tumor. And when you do the ETV in this case, straight away you can see that there is actually the tumor there, but of course we actually will go, right, you can see the tumor here, right? And then you look at the two memory bodies, and you can see the floor. And you can see actually the floor pulsating is quite thin out, and there are actually white deposits there. And these deposits are actually metastatic lesions as well. And here you can see we just, usual way I do an ETV, use a blunt tube and then make a hole and then actually pass the Fogarty balloon inside, right, and then expand it. And actually as we go along, I'm just running the fast, you can see we're through, right, you can see the vessels inside quite clearly, and that's the hole. And then after that, we just biopsy. And many times, actually, the biopsy can actually cause a bit of hemorrhage, but usually the hemorrhage will stop. So like in this case, there was a bit bleeding, okay? And you see the bleeding stops. That's it. So this turned out to be a pineal blastoma, right? Now, sometimes it may not be possible to see the tumor when you're using the same burr hole, and then when you try to turn the scope backwards, it may actually damage the fornix. So in situations like this, you can't see the tumor, right? You may want to consider using a flexible endoscope if you have one. Otherwise, you might want to consider putting a separate frontal burr hole for endoscopic tumor biopsy, and you use tumor image guidance to help you so that you don't damage the foramen row. So like this case, where the thing is done through the midline, so you can see how the burr hole is made through. You can go through the foramen row, and as you go in, you see the tumor very nicely here, right? And you can actually just do a biopsy of this. Even then, you can see, there is a bit of damage to the anterior part of the foramen row, but it's very minimal child as well. And this turned out to be a germ cell tumor and germinoma. Okay. So you can, as I mentioned, you can see metastatic lesions. So this is a child boy that we did, and actually when you see on the floor, these are the memory bodies. You can see actually a reddish lesion here, and this actually was a metallic deposit, which was actually biopsy, and it also turned out to be a germinoma. Right. So see, this was the after we took the biopsy here, but we were able to see the tumor took a biopsy, and both were the same. Now, what about open surgery for pineal tumors? So this indication is when you're unable to obtain a biopsy, or biopsy shows that tumor is not a germ cell tumor. Right? If it's a benign teratoma, you also need to consider open surgery because, right? So, in some cases, if the imaging suggests a benign teratoma, you might want to consider straight away open surgery. And then, of course, second look surgery, right? So what are surgical approaches? The most common would be either infratentorial suprasellar approach or the occipital transtentorial approach, right? Some people actually do a posterior intervention approach. And then in the past, we used to do stereotactic biopsy, but we find actually it's quite dangerous procedure. So most people have abandoned it, especially with the availability of endoscopy, right? So the infratentorial suprasellar approach, I think most of us are very familiar with now. Basically, patient usually is either in the sitting or standing position, sitting or the concave position, and then basically you go above the cerebellum, all right, under the tent, and the tumor is usually there. Right, so this is the anatomy, and usually this is the vein of Galen, the base of the vein of Rosenthal, and the tumor is usually just beneath there, and right, usually either sitting or a concave position. Okay, and the burr holes you make in such a way that actually you're just at the level of the sinuses or a bit of exposure to the sinus, so that you can then just go when you go your open the dura, you're just above the cerebellum, right? And various ways of doing it. So you can see here, as you open up, right, then you see the veins as you go in, and you see there's a very thick layer of arachnoid tissue that you dissect. And when you do that, after the dissection, you usually see the tumor. Okay, and then here, the tumor is here, right? You exercise it, and then you take out. And when you remove all the tumor, you can actually see the roof of the third ventricle and even the interthalamic adhesion here, right? Now, more and more people are using what they consider as an endoscopic suprasellar approach. Actually, you use the endoscope as an adjunct to the microscope, right? Or actually, in many now, what people are doing is using the endoscope as the only optical tool, right? So, and they use the paramedian suprasellar approach, so you avoid the occipital sinus, and you sacrifice less bridging veins. So, for instance, this is what you see with a microscope. This is what you can see with an endoscope. So very nice picture, but remember you're working in 2 dimension, right? And so if you check the literature, there are several technical papers showing how you do it, purely endoscopic removal, right? So in some cases, just doing the usual procedure, but in some cases, as you can see here, actually just 2 separate burr holes, right? Not even doing a true suprasellar approach, but just going in laterally, avoiding the sinuses and the veins and so forth, right? So these are things that people are doing now more and more. Now, the other approach is the occipital transtentorial approach. In this approach, it actually goes sideways through the lifting up the occipital lobe on one side, see the tentorium, you make a cut into the tentorium, and when you do that, you're actually, you make a cut through the tentorium, you're actually over the, a little bit more lateral aspect of the tumor, just below the vein of Galen, and between the vein of Galen and one of the basal veins, right? And so usually a patient is in either a so-called semi-prone position or 3/4 prone, all right, with the head tilted to the side. And then from there, right, you actually just retract the occipital lobe. So be careful, because one of the problems could be actually blindness as you're retracting onto the medial part of the occipital lobe, right? And then you expose the tentorium. These pictures are not so clear. I'll show you some more. So in this case, where you actually are making the retractor is there, right, lifting up the temporal lobe, and then you can see once you move in, you can see the veins there after you've cut the tentorium, right? And another approach you can see where you cut the tentorium is cut, you just retract this, and you can see the tumor down here very nicely. Okay, and then you can, once you remove the tumor, so you can see this is part of the basal vein as well. Okay, and in case where there's a residual tumor here, and you can see in this case the child is actually just in the prone to the head turned to one side. As you can see, you retract, and then you make a cut in the tentorium on the floor, and you can see straight away as you remove it, you can see this sort of the same view of arachnoid, and then you can see the tumor and can start removing the tumor, right? And then you can actually also use the endoscope to help you have a better view. I'm not that familiar with this posterior hemispheric approach, right? But it's again, you can even just go through in the back here, right? Actually, more or less above the splenium, and then you can actually get into the tumor as well. Okay. And some people like to do it with the one side down, so that gravity will help to actually allow the retraction of the lobe into the midline. Now, frequently we ask this question, which is the better approach, intratentoral approach or the oxbow transdental approach? So if you look at the lesion, if you're coming in from the supratental, of course, when the lesion is higher, the infratentoral supracellular approach is better. If the lesion is below, actually the transdental approach may be better. But the reality is that these tumors are so rare, right, that in many centers you may end up doing 2 or 3 a year or even less than that. And even in our place where we see maybe 5 to 6 cases of pineal tumors a year, many times because they are germ cell tumors, we don't even operate. So my suggestion is that you learn to do one approach well, and all the time you just use that approach, because it still be better than trying to do an approach that you are not familiar with. Now, there are complications. Now, complications could be related to the sitting position. If you're using a supracellular approach, embolism, tetraporesis, you can injure the cortex, especially using oxbow transdental approach. There could be vascular injury, especially venous injury, infarct, and deep venous injury can be quite severe, can cause massive brain swelling. The operation will be, you have to abandon the operation in those sort of situations. You can get post-hemorrhagic operative hemorrhage, you get brainstem injury, extraocular movement dysfunction because of injury to the tectum, right? And then of course cerebellar injury and ocular mental state. And so surgery is not without risk. There is a mortality of almost 5%. Morbidity also is more than 5%, right? Of course, surgical risk in biopsy is much lower. So there are protocols that you can use, and so this is a protocol that we follow very much from Paul Steinbock and his group. And this is actually, in the pediatric neurosurgery textbook published more than almost 20 years ago. So if you have a pineal tumor on, especially a suspected germ cell tumor on CT MRI, of course you do the serum markers, right? I look for tumor markers in the serum. If there's hydrocephalus, then you consider ETV or shunt, you take CSF markers and also ETV biopsy. If there's no hydrocephalus, you might want to do an LP in the lumbar puncture to look for CSF tumor markers. And of course, then if the tumor markers are positive, and then you consider germ cell tumor. So like look at this 15-year-old boy, okay, calcified pineal region, pineal area. Middle abdominal pain, actually, then on history, he's 3 months of actually polyuria, polydipsia, loss of weight. So he seems to be having this diabetes insipidus, and the Paranormal is positive, so he cannot cut words, right? And then his beta ACG, alpha fetal is negative. We actually did the ETV and performed biopsy. It's germinoma. So here the markers are actually negative. Now, actually, when we take the CSF at the same time, we also found that the beta ACG was raised, right? Alpha fetal protein was normal, but this was a germinoma. Okay. And after the chemotherapy and radiotherapy, you can see the tumor's gone. He didn't need surgery to remove the tumor mass. Now, if you are able to, if you find that the tumor markers are positive, right? So either beta AC more than 50 or alpha fetal more than 25, no biopsy is needed because this is a malignant germ cell tumor, right? Our patient needs chemo and craniospinal radiotherapy, and then you will consider surgery only if there's residual tumor. Okay, so look at this case of a tumor in the pineal region, 14-year-old boy with 2 weeks of vomiting, right? In this case, the serum beta ACG is very high, 1,800. So basically, this is probably a choriocarcinoma. And then, of course, because it's quite small, so actually we wanted to do an ETV because there was a bit of hydrocephalus, but the former row was actually too small. So actually in the end, actually EVD was inserted because of bleeding and then subsequently converted to a shunt. But of course, we took the CSF and the beta ECG was also a little bit on the high side. Right. So this was, and because beta ECG was high, we actually just give chemotherapy, and after 2 courses, you can see the tumor has shrunk. Okay. Now, 13-year-old boy with giddiness, polyuria, polydipsia, again, so diabetes insipidus. You look at the scan, it's like the periventricular lesion that it's actually all coded tumor. And actually, again, the beta ECG was maybe slightly raised, but then we did a lumbar puncture because he didn't really have raised pressure, and the beta ECG was high. So choriocarcinoma, but we did biopsy before chemotherapy, after chemotherapy. So again, you don't need to take a biopsy for these type of cases. Now, if you have alkaline phosphatase, you are able to do this test, then actually you don't need, if it's raised, you assume it's germinoma, and you treat either as for metastatic or non-metastatic disease, depending on how you, when you create the tumor. Then the one thing that you have is when the tumor markers are negative. So when you have tumor marker negative, right, and if there are indicators, CT or MRI, clinical find typical germinoma, you have 2 options. 1, you biopsy and treat based on histology, or 2, you can actually give a trial of chemo or radiotherapy. And this is actually what was used to do in the past with pineal tumors. They give 2 weeks of radiotherapy. If it shrinks, it means a germinoma, you continue treatment. If it's not, then maybe not germinoma, then you actually do open biopsy resection and so forth. Or if the CT findings is not typical germinoma, you just do open biopsy resection. Right, so look at this case, right? So the 3-year-old lady, history of migraines, and MRI shows a pineal tumor, right? Markers are low, almost normal, right? And this approach was used, a supercell approach, and guess what? Meningioma, okay? Now, 11-year-old boy, headaches for 1 week. You can see on this CT scan, there's actually, fat, right? So this is most likely a teratoma. You look at the MRI, okay, there's actually all these vesicles inside. So it's a heterogeneous type, and this is quite classic of a germinoma. Now, this patient underwent ETV with biopsy tissue was not definitely because the wall in front was very thick. And anyway, this we also suspect that this was a germinoma. So patient underwent supercellular infantile supercellular approach. It took a very bloody tumor, and then a large part of it actually cheesy, hairy, solid plus soft grayish components. Now, histology was that of a mixed germ cell tumor because there was presence of germinoma and also benign teratoma. Now, post-op patient actually had upward gaze palsy and also a right thalamic infarct, which actually we saw, right? So he underwent chemo and RT, and this was a post-op scan. So second look surgery is the surgery that you perform for residual tumor following chemotherapy and or radiotherapy, especially if the tumor markers are still positive. But sometimes tumor markers are negative. It suggests that there could be a teratoma. You would need to go and remove that, right? What the good thing is that it's a smaller tumor mass most of the time, and usually less fast and less vascular. And of course, the tumor markers are negative, as I mentioned. Most likely, it could be a mature teratoma, but it could also be scar tissue. Right, so this case was actually a mixed germ cell tumor. After chemotherapy, the tumor shrank, but they don't continue to grow. The parents didn't want further surgery until 6 years later, and we actually went to take out, but there was still some residual tumor left behind because it's quite deep. And then the tumor actually recurred, and then when it did the histology, the teratoma portion became adenocarcinoma. So this patient actually subsequently died after about 12 years. So in summary, pineal tumors are uncommon and they're very diverse. So in our part of the world, germ cell tumors are commonly seen in the pineal region. The non-germinatus germ cell tumors will secrete tumor markers but not germinomas. And the protocol management strategies are useful. Surgery or biopsy for secrete germ cell tumors may be initially avoided, and radiotherapy, chemotherapy can be primary treatment in the presence of tumor markers. Pineal tumors commonly present hydrocephalus, hence treatment ETV and concurrent biopsy is key. right? Excision is necessary for teratomas and non-germ cell tumors. And second look surgery should be considered where there are residual after adjuvant therapy. I thank you very much and just wanted to invite all of you to the ISBN meeting, which was supposed to be held in Singapore last year. Of course, now it has been postponed. And this meeting is now going to be combined with the World Congress of Neuroendoscopy, and it's going to be in November, starting 14th of November, 2021. So hope to see you all here in Singapore and hope that everybody will be safe and well. Thank you.
Thanks, Wen-Tu. That was really a masterful overview of the topic, and clearly you have lots of experience. I think we're all looking forward to both those meetings at the end of the year. I hope we can attend in person. So we've got some of our panelists who join, and I think it might be sensible to ask for comments. So we've got Nasser Al-Gender who's joined, Moody Qureshi, and Graham Fegan. Maybe in that order. Nasser, any comments you want to make?
Yes, please. I would like, first of all, to thank all of you for organizing this educational session. And I would like to congratulate Professor Su about this great talk, really. And really, it was very illustrative. And I hope this pandemic lockdown will be finished and we can meet soon in Singapore in the ISBN meeting. I enjoyed your presentation. However, I have some inquiries. First of all, Professor Su, I understand that you have great experience in treating Pineal region tumors. I would like to know, I listened to all the lecture with all the treatment options. I would like to know how you are going to deal with a patient with Pineal region tumor. Are you going to ask for markers first? Do you believe in serum markers or only cerebrospinal fluid markers? And is it safe to do lumbar puncture for these tumors with increased intracranial pressure? Do you do it as a routine for all patients? And on what basis do you build your strategy, on the pathology of treatment mainly? And I have another two questions. How accurate is magnetic resonance imaging in differentiating between the pathology? Because it's very important to know the pathology before putting strategy of treatment. It's enough for all these questions. Thank you.
Okay, thank you. Okay, so I think markers, because in our part of the world, germ cell tumors, as I say, very much more common. So markers are important. Serum markers are probably the easiest and the most, and they are actually, if they are raised and you see a tumor imaging, shows either a pineal or even supracellular tumor, and the markers are highly positive, it's a germ cell tumor, right? A secretory germ cell tumor. We don't even do a biopsy. But of course, most of these patients have hydrocephalus. So usually we will have to do an ETV as well. Now, is it safe to do lumbar puncture? Some of the tumors, if there's no raised pressure, and if the serum markers are normal or negative, we will do a lumbar puncture. We don't do for every case, right? We don't do lumbar puncture for every case. We only if the serum markers are negative and we want to test for CSF markers, then we'll do lumbar puncture. But many times, because there's actually hydrocephalus, we will get CSF markers as well. Does that help you answer? Okay, number one. Then number two, I think imaging itself just tells you the presence of a tumor in the pineal region. Obviously, if there is a bipolar or means a tumor in the pineal region and in the supracellular region, right? So a bipolar tumor, it's usually a germ cell tumor. But even then, we'll still look for markers and we'll still, if necessary, do a biopsy, right? Because I think there's a difference between a germinoma and the chemotherapy, and germinoma and secretory germ cell tumor is a little bit different, right? The chemotherapy for the secretory germ cell tumors are much more toxic because, and usually would include also cranial-spinal axis irradiation itself. So I think it's important. So like what Christian and Rose say, radiology is not pathology. I think we always remember that very clearly for many of us who have attended talks that he gave. Have I answered most of your questions already?
Yes, thank you very much.
Thank you.
Thanks, Nasser. Maybe a comment or a question from your side, Moody?
Yeah, thank
you. Have Moody, you have
thank you very much. It's a pleasure, Professor So, to hear your talk all the way from Singapore. We're extremely pleased on behalf of CANS to hear your talk. And I'd like to thank Llewellyn and Mohammed Beltaghi for having commenced this pediatric webinar series, and to get such eminent speakers for our young neurosurgeons and ourselves to listen to. I won't have very many technical questions because really you've provided a superb overview of the problem, its diagnosis, your protocols of treatment, and the options of surgical management. So really you haven't left anything in my mind that raises a query. Thank you very much for an excellent talk. Thank you.
Thank you. Thank you.
Thanks, Moody. Graham, if you have any comments, please just unmute yourself.
Yes. Right. Hi. Thank you. Thank you, Llewellyn, and thank you, Mohammed. And I feel quite nostalgic actually seeing you online.
I know.
The last time, in fact, Llewellyn, you were there as well. The last time we met in person was in Kolkata in February last year. And I got to Kolkata I knew there was some silly virus that was causing trouble in China. And I didn't really pay much attention to it. And I'll never forget meeting you at the hotel, and you were terrified. You said, "Whoa, there's big trouble coming." And it's the first time I really sat up and took notice. And my goodness, you were right. So on that basis, I'm going to believe everything you ever told me ever again, because you were right. You were right big time. But thanks, Wanchu. It's a lovely talk, and you're just such an extraordinary expert on this topic. You've seen so many of these kids. There are just really three things that I would like to highlight. The one is to always think about germinoma. Germinoma has such a special and unique treatment I never really thought about actually until this evening. Is why is it that germinoma responds so quickly to radiotherapy and to chemotherapy? It's extraordinary. In the old literature, there's even talk about if patients present with germinomas with hydrocephalus, just putting in an EVD and giving them radiotherapy. Within a few days, the tumor's melted. And I've never really thought about why it is that these tumors respond so quickly. So if you have any thoughts about that, I'd be interested to hear that. The second thing is hydrocephalus in pineal tumors. And I don't think it's hard to think of a condition in neurosurgery that endoscopy has made such a difference to as pineal tumors with hydrocephalus. And I really loved your approach to this tidal kind of debate about ETV first or biopsy first. And I think it's really determined by the clinical presentation. And hydrocephalus usually and raised pressure usually is the problem. And as you said, I think one needs to deal with that first. And oftentimes